Hello, my name is Sonia Harris, and together with Dr. Amy Krentzman at the University of Minnesota School of Social Work, we have developed this instructional video on medications to treat opioid use disorders for social workers and child welfare. This video will first briefly review brain science and how medications work in the brain. The second section will describe the medications to treat opioid use disorders in more detail, including research on their effectiveness. This video will conclude with an overview of disparities present in medication access and some specific actions social workers can take. Medications to treat opioid-related disorders is the use of specific medications either alone or in combination with counseling and behavioral therapies. These behavioral therapy approaches include motivational interviewing, cognitive behavioral therapy, relapse prevention therapy, and community-based supports. The use of medications has been found to be effective in treating opioid, alcohol, and nicotine use disorders. Studies indicate that medications helps people sustain recovery and stay in treatment, reduces and prevents the likelihood of overdoses and all-cause mortality, decreases criminal activity associated with opioid use, and improves birth outcomes for pregnant patients. In order to understand the ways in which medications to treat addictions work, it can be helpful to review the science of how the brain works. Simply put, neurons are cells that transmit information from the brain to other parts of the central nervous system. Neurotransmitters are the body's chemical messengers. They are released by neurons. Neurotransmitters help you move your limbs, feel sensations, keep your heart beating, and take in and respond to information. A synapse allows signals to pass from one neuron to another. Synapses are key for brain functioning, and especially memory. Receptors are proteins on the membrane of a brain cell. Often they're described as like a lock. Many medications for opioid treatments are either full agonists, partial agonists, or antagonists. It can be helpful to become clearer about these distinctions. Full agonists mimic the action of a neurotransmitter. They activate a specific receptor in the brain to produce a specific response. A partial agonist is a type of medication or opioid that activates a specific receptor in the brain, but to a lesser extent than a full agonist. Partial agonists displace other agonists from binding to the receptor. It produces a partial response or stimulation of the receptor compared to a full agonist. An antagonist is a substance that blocks or inhibits the activity of a specific receptors in the brain without producing an activation. Antagonists can counteract or reduce the effects of agonists. You can think of an agonist as a key, while an antagonist is like a roadblock. The next slide makes these distinctions even clearer. Here is a helpful image courtesy of the Pew Charitable Trust that portrays the difference between a full agonist, a partial agonist, and an antagonist. You can see that methadone is an agonist. It is like a key for the receptor, while naltrexone, an antagonist, blocks the receptor. Here are 4 examples of medications approved by the FDA for treatment of opioid-related disorders: methadone, buprenorphine, or buprenorphine naloxone as a combination medication, naltrexone, and naloxone. The first 3 medications on this slide are prescription medications taken daily or monthly that work to prevent withdrawal and/or prevent feelings of euphoria associated with opioid use. The last medication, naloxone, is an emergency treatment for overdose. This presentation will focus on medications to treat opioid-related disorders, but it is important to note that there are also medications for other substance use disorders. For example, there are 3 FDA-approved medications for the treatment of alcohol use disorders. These include acamprosate, disulfiram, and naltrexone. Acamprosate and disulfiram are both daily medications that reduce alcohol consumption. Naltrexone will be covered in more detail in this presentation, as it is also used in the treatment of opioid use disorders. For the treatment of tobacco use disorders, there is both nicotine replacement therapy and medications. Nicotine replacement therapy helps to relieve nicotine cravings and withdrawal symptoms. Nicotine replacement therapy comes in many forms, including sprays and gum. There are two FDA-approved medications for this purpose, bupropion and varenicline. Varenicline boosts the odds of successfully quitting compared with unassisted attempts. Now for more detail on each of the medications to treat opioid use disorders, starting with methadone, which is the first approved drug by the FDA. Methadone is a long-acting, full agonist used in the treatment of opioid use disorders and used for pain management. Methadone is a synthetic opioid, meaning that it is made in a laboratory and it is not derived from the opium poppy. Currently, methadone can only be dispensed for opioid use disorders at a certified opioid treatment program center. But there is pending legislation that would make this change so that methadone would be available more broadly. When used for pain management, certified programs are not required. When taken as administered by the methadone clinic, it is generally safe. Nevertheless, it has addictive potential, like other full opioid agonists, and it can cause an overdose if the dose is too high. Thus, it is closely monitored by the treatment program. Methadone is also safe for pregnant and breastfeeding patients, but in some cases, infants will develop neonatal abstinence syndrome, which is when an infant experiences withdrawal caused by exposure to a substance in utero. Thus, it is important for a person who is pregnant or wants to become pregnant that is on methadone to consult with their medical team about medication safety around pregnancy. Overall, methadone has been found to reduce risk of overdose and reduce all-cause mortality when used as prescribed. So what more can be said about the effectiveness of methadone? Research evidence supports that if a patient gets an effective maintenance dose, that is, individualized specifically for them, then they are less likely to use or inject drugs and will be at a lower risk of overdose. Methadone is also effective in reducing disease transmission and crime associated with opioid use. Additionally, research found that methadone treatment, even without additional behavioral health services, still reduces likelihood of using other opioids. The following bar chart shows a result from 6 different studies. The x-axis, or the horizontal line, shows the 6 different studies by name. The y-axis, or the vertical line, shows the percent of patients testing positive for opioids during the study. The red bar, which represents the control group, are the percentage of patients who tested positive for opioids without using methadone. The blue bars, which represents the groups treated with methadone, are the percentage of people who tested positive for opioid use. In all 6 studies, the percentage of people who tested positive is lower when treated with methadone, which supports methadone effectiveness. Now let's discuss the second opioid use disorder medication. Buprenorphine is the first medication for opioid use disorders that can be prescribed and dispensed in physicians' offices. Buprenorphine is a partial opioid agonist. Like methadone, it is also an opioid used for treatment. Buprenorphine can cause precipitated withdrawal if given in too high of a dose and too close to the last use of a full agonist. Buprenorphine, like methadone, also requires daily dosing. The medicine lessens the effects of dependency by reducing withdrawal symptoms and cravings. Because the effects are weaker than full agonists, it produces these effects with lower amounts of euphoria. Buprenorphine has a ceiling effect, meaning that the effects have a limit after a certain amount and taking more will not increase the effect, i.e., taking more buprenorphine will not increase euphoric effects once the ceiling has been reached. Buprenorphine is very unlikely to ever cause respiratory depression or overdose. Buprenorphine is also safe for use in pregnant and breastfeeding patients. Buprenorphine is also present in a medicine that combines buprenorphine with naloxone. This combination medication pairs a partial agonist with an antagonist. Primarily, it works the same as buprenorphine. These medications are combined because clients might be tempted to inject buprenorphine because of its euphoric effects. Naloxone is added to discourage injection of the medication. If a client injects the combination medication, individuals will feel withdrawal symptoms from the naloxone, and the naloxone will prevent buprenorphine overdose. This combination medication has been found to reduce the rate of opioid use-related emergency room visits and overdose. What else is known about the effectiveness of this drug? Research evidence on effectiveness of buprenorphine indicate that effectiveness is based on getting the right dose. At the correct dose, patients are almost 2 times more likely to stay in treatment. This bar chart below shows the results from 2 different studies. The x-axis, or the horizontal line, shows the names of the 2 studies. The y-axis, the vertical line, shows the percent of patients testing positive for opioids during the study. Like the other bar graph, the red bar represents the control group, or the percentage of patients who tested positive for opioids without using buprenorphine. The blue bar, which represents the group treated with buprenorphine, are the percentage of people who tested positive for opioid use. In both studies, the percentage of people who tested positive is lower when treated with buprenorphine. Additionally, evidence supports that the use of buprenorphine in pregnancy is associated with a lower risk of adverse neonatal outcomes than methadone use, but there are similar adverse maternal outcomes for the 2 medications. So generally speaking, buprenorphine and methadone are found to be the safest medications for the treatment of opioid use disorders. When used for indefinite periods of time, these medications reduce use of opioids and retain patients in treatment. Use of methadone or buprenorphine for individuals with opioid use disorders have decreased risks of mortality compared to individuals untreated. Now we will move on to the 3rd medication in our discussion in this video. Naltrexone is used in the treatment of both opioid use disorder and alcohol use disorder. Naltrexone is administered as a monthly extended-release intramuscular injection. It is an opioid antagonist. Naltrexone is non-addictive. It works by blocking the euphoric effects of opioids and alcohol, and over time, it reduces cravings. Remember, an antagonist is like a roadblock. Because of this blocking effect, if a person sustains an injury or accident, pain control will be difficult because the effect of some pain meds would be blocked by this medication. Before starting treatment, patients must be completely withdrawn from opioids for at least 7 to 10 days so that they do not experience withdrawal symptoms when taking the medication. When patients are on naltrexone for a while, if they resume illicit opioid use, then they might have an increased risk of overdose because naltrexone rapidly reduces tolerance to opioids. Therefore, if patients attempt to take the same amount of an illicit opioid that they have been taking prior to treatment, they may overdose. Unlike methadone and buprenorphine, naltrexone is not currently recommended for pregnant patients. What more is known about naltrexone effectiveness? There is actually limited empirical evidence on the effectiveness of naltrexone. It is also less frequently prescribed than both buprenorphine and methadone. Providers have cited that this lack of prescribing is in part due to the need to be completely withdrawn from opioids prior to starting the medication. Despite being less frequently prescribed, there is evidence that it is helpful. One 2010 randomized placebo study found that naltrexone decreased use of opioids and that patients did remain in treatment. So this is the last medication we will be covering in this video. Naloxone, frequently referred to as Narcan, is an opioid antagonist that rapidly reverses opioid overdose in as fast as 2 to 3 minutes. Naloxone works by binding and temporarily blocking opioid receptors. The medication, which can be given as an intranasal spray or administered intravenously, can quickly restore breathing if breathing has slowed. The intranasal spray is available as an over-the-counter medication. Naloxone is a temporary treatment, meaning the effects do not last long, approximately 30 to 90 minutes. What this means is that after the medication wears off, overdose is still possible while the opioid remains in the system. Thus, it is essential for patients to go to the hospital and/or be monitored for at least 2 hours after the last dose of naloxone to ensure overdose does not occur. Individuals with a physical dependence to opioids may experience withdrawal symptoms immediately after naloxone is administered. So finally, what more is known about naloxone effectiveness? Research evidence supports that naloxone is effective in reversing overdose. Additionally, increased access to naloxone through distribution programs and access laws have been shown to reduce overdose deaths without increasing opioid use. One statistical model from the National Institute on Drug Abuse suggests that high rates of naloxone distribution among laypersons and emergency personnel could avert as many as 21% of opioid overdose deaths. 21%. Family, friends, and social workers can go through trainings to learn how to effectively administer naloxone as a life-saving intervention. So in conclusion, there are 4 different medications to treat opioid use disorders. Each of these medications are effective for treatment. So despite widespread evidence of its success, the barriers to adopting medications for treatment of substance use disorders are challenging, and disparities exist in access to these medications. While access laws and FDA approval has made attempts to make these medications more accessible and available, the need has outpaced the healthcare system's ability to train providers. Insurance coverage is also a major barrier to accessing medications. While the Affordable Care Act does mandate insurance coverage for substance use disorder treatment, it does not specify which treatment modalities must be covered. Stigma also impacts access to treatment, often related to misinformation and misconceptions around substance use disorder treatments and medications for treatment. Additionally, Black, Indigenous, Latinx, and other BIPOC communities are disproportionately impacted by the drug overdose crisis. Since the COVID-19 pandemic, the percentage of fatal overdose in Black, Indigenous, and Latinx communities has risen. Yet Black and Latinx patients are less likely to receive medications than white patients. Naloxone is also less likely to be used to treat Black patients. BIPOC individuals are also less likely to live near a provider of medication for opioid use disorders, making it nearly impossible to sustain methadone treatment, as just one example. So what can social workers do? First, social workers have a critical role in shifting the culture around substance use disorder and medications for treatment. They can address stigma around substance use disorders, especially the language used to describe folks with substance use disorders. Second, social workers with clinical training can provide the psychotherapy components of some treatment modalities used in conjunction with medication. For example, motivational interviewing or group counseling. Often, psychotherapy is a required component of medication treatment. Additionally, some programs require case management support, which is within the scope of social work. For example, support with connecting with family members or finding housing. Social workers can also familiarize themselves with the SAMHSA Behavioral Health Treatment Locator tool, which is accurate information about opioid specialty clinic locations. Finally, social workers can facilitate the use of these helpful medications by educating patients, families, and advocating for training programs for social workers and other community outreach members. Here's the homepage for the SAMHSA Behavioral Health Treatment Locator tool, which was mentioned in the last slide. We would like to thank Dr. Kirk Brower, Dr. Kirk Devine, and Dr. Sarah Whitehouse for their generous support and guidance as we developed this video. We are so grateful for their involvement. That concludes our informational video on medications to treat opioid use disorders. Thank you for your engagement and participation. The next slide will include a link to our reference page.